Hello friends, this is a case of umbilical hernia, primary umbilical hernia, and we are planning a robotic TAPP mesh repair of this hernia. Now, if you see, this is our area of interest, that is umbilical defect, almost 2 centimeters in size, zippy, pubic bone, and costal margins on either side. And if you can appreciate, this is the area of anterior superior iliac spine. Patient is in supine position, and the plan here is to insufflate the abdomen from Palmer's point using Verey's needle. And once the abdomen is insufflated, we'll mark the area of interest. Normally, for majority of our primary umbilical hernias, we make markings of 15 into 15 centimeter around the hernial defect. See transversely 7.5 on either side, midpoint, and then craniocaudally 7.5 centimeter on either side. Now, normally in our routine practice, if we are dealing with primary umbilical hernias, the normal size is around 2 to 3 centimeter. That's why these markings. And if we are dealing with larger hernias, then probably the size of the marking as well as the size of mesh will be slightly different. And similarly, anybody can choose the size of the marking as per their convenience. This patient has good abdominal planus, and what I mean is has optimal space for port placement. Now, typically these are the types of patient. If you want to start your robotic or laparoscopic TAPP journey for ventral hernias, a BMI of around 30, male patient, primary umbilical hernias with good abdominal planus are the patients to start your journey. This is the level of costal margin, and we are marking at almost 10 centimeters here. Normally we can keep at 7 to 8 centimeters, but since this patient has good planus, we went further laterally. And this is anterior superior iliac spine. This is a rough marking of anterior axillary line, and we normally tend to be proximal to it. The limit of port placement should be proximal, and we try not to go beyond this line. The level of second or the camera port at the level of umbilicus, and the level of third port. And if you see carefully, we are at a good distance away from anterior superior iliac spine. Here, roughly the distance between our ports is 7 to 8 centimeter, and we are almost 10 centimeters away from our line of incision that we have already planned. You might not get such conducive abdomen in all your cases, and there may be scenarios in which the abdomen is small and the distance between two ports might be a challenge. It might be around 5 centimeters. Although the recommended distance between the ports is around 8 centimeters, with time and experience, this can be done with these ports as well. Early in experience, what we can do is we can start with a 5 trocar from the Palmer's point, and then we can place the robotic trocars under vision. Coming back to our case now. Before placing our first port, we typically give 20 to 30 degree of left up tilt to the table, and then we place our first robotic trocar. One can also use an optical entry here for placement of first port that can be later on changed or upgraded. We need to be extremely cautious and careful while putting our first robotic trocar, and once we placed it inside abdomen, we quickly do a diagnosticoscopy there just to be sure that we are not causing any kind of injury to the visceral structures. And there you see the Verey's needle. Now if you see carefully, this is the level at which the patient's body is placed, and the hand is hanging by the side with some kind of underarm support, so that there is no kind of interference between the robotic arms and the patient's hand or the table. Now the second port that we are going to place is the lowermost port, and we are just ensuring that we are good distance away from anterior superior leg spine. If you see here, we are almost 3-4 finger breadths away from anterior superior leg spine, almost in the line of the marking that I was made earlier. After placing these two ports, that is the upper and the lower ones, we place our final, the camera port, right in between these two ports. Once ports plates, we select the anatomy, that is in this case renal, and the side from which patient cart is coming, and then we deploy for dock. We'll be using three arms here, so I'm stowing away the first arm, and we'll be using a third arm as the camera arm, right? We need to ensure that the cannula and the robotic arm are parallel for docking, and also ensure that the cannula doesn't come out at this moment. Once the instrument clutch light becomes solid, it is ready for use. The camera is ready for use. You can gently press it and take it under your control and put the camera inside abdominal cavity. Now, what we are trying to do here is we are trying to select the target anatomy. It is important to note here is that we are not targeting the anatomy as umbilicus, and we always select the target anatomy as the distalmost point of dissection. Once targeting complete, we quickly dock our both arms. Again, an important step, the instrument insertion. So when the ports are placed and the instruments are in place, can you appreciate the black and yellow line? That signifies the location of active instrument, and the insertion has to be under vision. Once docking is complete and all instruments in place, we burp all our arms before moving on to surgeon console. Here you can see this is the clearance button that can be used to improve clearance in between the arms in cases of crowding. Here we have good space in between the arms without any kind of overcrowding, and we are good to move to the console now. Thank you.